From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Welcome to this JAMA Clinical Reviews podcast. I am Dr. David Simel, Associate Editor for JAMA. In this podcast, we will be discussing guidelines for the care of patients with Acute Respiratory Distress Syndrome, commonly referred to as ARDS. The new guidelines were released on June 16, 2023 by the European Society of Intensive Care Medicine, released online in the journal Intensive Care Medicine. To address this topic, we are pleased to be joined by Dr. Derek Angus, who is the Chair of Critical Care Medicine at the University of Pittsburgh School of Medicine. Dr. Angus is also a Senior Editor at JAMA and the author of the clinical guidelines synopsis that appears in JAMA in the July 23, 2023 issue. Dr. Angus, thanks for joining us today.
You're welcome, David.
Well, let's start with definitions, which is how we like to begin things on our clinical guidelines synopses. ARDS is non-cardiogenic pulmonary edema, where the patient is mechanically ventilated and requires at least 5 centimeters water of positive end expiratory pressure, which we call PEEP. So as a physician who's not a specialist in intensive care medicine, that definition has always felt arbitrary to me, primarily because as patients have deteriorating oxygen, we often have an informed suspicion that they already have ARDS, but they're just not intubated yet and don't meet the PEEP definition. How did the guidelines group handle that?
So let's be clear, a guidelines committee isn't in charge of coming up with a new definition, but it's pretty hard to know how to use the guidelines or interpret the guidelines unless you know how you're going to define and diagnose who has ARDS and who doesn't have ARDS. And what you described there are the current criteria for diagnosing ARDS, and you're right that there's a degree of arbitrariness to them. What is not arbitrary is the conceptual biomechanistic definition of ARDS. So really for decades now, we've all been pretty comfortable with the idea that what ARDS is the umbrella term, a syndrome for all these moments when some sort of injury, either coming in from outside, like pneumococcal species coming into the lung, into the airways, or some sort of toxin in the blood perfusing the pulmonary vasculature, something causes an injury to the lung that causes this so-called non-cardiogenic pulmonary edema. And we get a thickening of the space between the capillary and the alveolus. We get damage to the lining of the alveolus, and we get fluid in the alveolar sac where there should have been air. And all of that compromises particularly oxygen transfer, gas exchange in general, but particularly the ability to oxygenate, and compromises lung function. So that's not arbitrary. Having said that, trying to operationalize that at the bedside is not easy and has been a debate for decades. How can you make sure that it's not due to cardiac failure? How can you rule out cardiac as the cause of pulmonary edema? How do you know there is actually pulmonary edema? How do you know it's acute? And so on. And so the current definition has been around for a decade or so, and it's actually a leaner definition than some of the older definitions, which involved using the Swan-Ganz catheter to rule out cardiac causes of pulmonary edema. But because ARDS was for so long the focus of clinicians taking care of patients who had this problem in ventilated patients, the current definition was still focused only on patients who were on the ventilator. And they were trying to standardize the PEEP because they were really interested in having a reliable measure of the degree of hypoxemia. And you can't measure that unless you have a strong measure of what you think the oxygen content is in the alveolus so that you can get an AA gradient. All that to say, the current definition is actually a pretty good, reliable, and consistent definition for patients who are intubated. This underlying process of injured lung developing pulmonary edema, surely that could happen before the patient is intubated. And the answer is totally yes. And so what did the Guidelines Committee do? Well, they alluded to something which we also remarked on, which is someone needs to update the definition and the criteria. And that definitely has to happen. That wasn't the job of the Guidelines Committee, but they didn't want to be hamstrung by the technical definition that restricted ARDS to just those patients who were on the ventilator. So, long-winded story. They also talked about the term acute hypoxemic respiratory failure, not otherwise explained by pre-existing lung disease or heart disease. The advantage of this is it gave them permission to look at what are the strategies someone might use when they're encountering a patient either before they're intubated to try to avoid them even having to be intubated, or in the many parts of the world with less access to modern intensive care where there may not even be access to a ventilator. And so it was a smart move by the Guidelines Committee to use this broader term, acute hypoxemic respiratory failure, and then enlarge their literature searches for exploring the evidence around the best things to do in the patient who isn't yet intubated.
Let's say I've got a patient, though, with acute hypoxemic respiratory failure, and their hypoxemia is progressing. The guidelines suggest some mechanical parameters for the tidal volume and PEEP, and you alluded to PEEP as part of the definition. Many of our listeners, like me, aren't intensivists, so could you just review the physiology here briefly and talk about how an intensivist sets up the ventilator in regards to a patient with acute respiratory distress syndrome?
So the ventilator is an amazing development. It was definitely a real technological breakthrough in the 20th century. Faced with the polio epidemic, people came out with round one of ventilators, these so-called iron lungs, these cuirass devices, which tried to mimic the way we breathe by trying to help expand the lung to draw in a breath. The modern ventilator doesn't do what the iron lung does. The iron lung tries to mimic the way you or I breathe. We take in a breath, we actually expand our chest cage and create negative pressure inside the lung. That's how we breathe. We pull air in from the outside because we're creating a vacuum. Mechanical ventilators are on the outside and they push air in. So during a breath, an inspiration breath, instead of what you learned in medical school about being at negative pressure, say negative 2 centimeters of water to get air flowing in, they're pushing in with positive pressure. And sometimes a lot more than 2 centimeters of water, sometimes 20, 30, or 40 centimeters of water to push the breath in. Now, when they push that breath in, for someone who was unable to adequately oxygenate and would otherwise have died, the ventilator is incredibly life-saving. But it's so non-physiologic that nearly every aspect of what we're doing can both be fantastic and detrimental at the same time. So you have to decide, how big should the breath be? And since you're pushing it in with positive pressure, you're concerned both about it being too big a breath and a breath that's under too much pressure, which could be injurious. Equally, at the end of the breath, because the lung is injured, etc., the lung can actually collapse down. And so you try to keep the lung open at the end of the breath, and that's what you use PEEP for. And then, of course, you have to say, how much oxygen am I giving? And oxygen is the lifeblood, but oxygen itself can be toxic. So when setting up the ventilator, you have to decide, how big should the breath be? How many breaths should there be? How much PEEP should be at the end of the breath? And how much oxygen should I be giving? All of these things have been the subject of all sorts of research, both because if you do too much, it can be a problem, and if you do too little, it can be a problem. In general, we have moved from larger tidal volumes down to smaller tidal volumes. And so the so-called 6 cc's per kilogram of ideal predicted body weight has really been the standard ARDS management for about 20 years now, since a landmark trial from the NIH showing a big drop in mortality. And the presumption was that these larger breaths were in and of themselves by over-distending the lung, they were actually exacerbating the lung injury and actually putting the patient at greater risk of dying. So you want to use smaller tidal volumes, which also means a higher rate, so you still get the same minute ventilation. We've been trying the right PEEP forever. We've tried to go with higher PEEP or lower PEEP, so-called best PEEP. It's hard to say what's right. The main thing to do is to not keep the PEEP unnecessarily high for too long. So you need at least some PEEP to keep the airways open a little bit. You can increase the PEEP if someone is having problems with oxygenation, and then you should dial it back down again when the oxygenation is improving. And remember, the other problem with PEEP is that PEEP plus the positive airway breath means the chest is at positive pressure, which means the venous blood returning into the chest to fill the heart has trouble getting into the heart. And so you can actually worsen shock and you can decrease the filling into the heart and so forth. So in general, we don't know the right PEEP, but we know that we want to give enough PEEP to get adequate oxygenation, but not more than that. The other thing that people sometimes play around with, if you're giving smaller tidal volume breaths, we know that every so often in normal life, we might take a big sigh or a yawn or a big breath, and that might actually help pop open alveoli, especially in an injured lung. And so people have spent a lot of time thinking about so-called recruitment maneuvers or sigh breaths. And at least at the time of the guidelines committee, when they were writing their analysis, there had been one large study conducted out of Brazil, but actually recruiting patients in many different countries, which was thinking that it would improve outcome by building in some recurrent so-called recruitment maneuvers. But actually, that study suggested that these aggressive recruitment maneuvers might even have been harmful, possibly again because it increased the positive pressure even more, causing cardiovascular collapse. And so in the current guidelines, they're not recommending the systematic use of prolonged recruitment maneuvers.
I gather then that what I should remember is lower of everything is better as long as it's working.
Intensive care rode on a wave of technological innovation in the 70s and 80s and just brought more and more of everything. And then we've definitely spent the last 20 or 30 years actually trying to pull back on a lot of the invasiveness. So a guiding principle in intensive care is actually about being less intensive and being less invasive.
Well, let's say you've got this patient with ARDS and you've done your best you can with the tidal volumes and the PEEP and the recruitment, and they're still having worsening hypoxemia. The panel recommended proning or turning the patient face down for several hours a day, which for someone who trained during my era is rather novel because everyone on a ventilator was flat on their back. So it sounds simple and a non-invasive strategy to improve oxygenation, but I know that's not so simple. Could you talk a little bit about that?
Proning, great topic. So the lung is where air and blood meet, but air and blood don't meet evenly all the way through the lung. Thanks to gravity, heavy blood is at the bottom and light air is at the top. And the lung isn't a perfect cube or a perfect box. And so proning is essentially recognizing that if you change which part of the lung is on the bottom, then you change the relative proportion of West zones. And so you're playing around with sort of the ideal matching of open alveoli that have air in them with alveoli that are getting a plentiful blood supply. And if you can tweak the lungs through gravity to get a larger part of the lung with more effective, essentially VQ matching, then you can improve oxygenation. That's the essence of it. And lying on your back is in many ways not the ideal arrangement. And even turning sideways can sometimes help, but certainly getting right the way onto your tummy is in many ways more advantageous. Now, it's not true for everyone because the lung is injured heterogeneously and it doesn't always play out. But for many patients who are having trouble with oxygenation, you can get a remarkable boost in the ability to oxygenate simply by rolling them onto their stomach. Now, simply by rolling them onto your stomach? These patients are incredibly ill. They're intubated. They've got lines in them. If you roll them onto their stomach, then you can't really see them. What happens to all those lines? What happens to their NG tube? It can be very frightening and scary for the ICU nurses and the ICU docs and so on. And so, although it sounds simple, people have spent a long time trying to work out how to do it. They've thought about trying to do it in like a striker frame, strapping the patient into the bed and rolling them. In reality, though, what has come out is with adequate training of the bedside team, even in regular ICU beds, it's pretty easy now, once people are trained, to roll patients over for up to several hours a day. And you can roll them over for 3 or 4 hours, roll them back for a while, and do this sort of rotating back and forth. And you just need to be careful and attentive to the fact that now you can't see the face properly. Make sure you don't pull lines out, but that's what all the training is for. And one real landmark study from France showed that proning had a massive effect on mortality, simply because it avoided then having to massively turn up all the dials on the ventilator. You could essentially use a gentler ventilation because you were getting much more effective gas exchange with proning. So proning has really become a go-to move in anyone in whom there is ongoing recurrent problems with getting adequate oxygenation.
Is proning a strategy for the non-intubated patient with acute hypoxemic respiratory failure?
So proning has been really widely adopted now for intubated patients. During COVID, many patients, even prior to being intubated, even themselves found that they were more comfortable lying on their belly. And there was a real movement to then say, maybe we should prone the non-intubated COVID patient. There weren't any randomized trials of this that really informed on it, but there was quite a lot of anecdotal and observational evidence to suggest that proning could be quite effective in non-intubated patients. It's highly likely that exactly the same principles that give the benefit in the intubated patient would also yield benefits in the non-intubated patient.
The guidelines for the intubated patient address patient ventilator asynchrony, and they advise us not to use routine neuromuscular blockage in ventilated patients. Could you describe what asynchrony is and what that experience is like for a patient?
If you remember, I was mentioning that the ventilator is profoundly non-physiologic. It's trying to push air into the chest. And it also sets the rate at which it does it. Often patients are sedated and pretty sleepy and not too aware. But if a patient is awake and they have a tube down their throat and the ventilator is shoving breath down their lungs, that can feel very uncomfortable. Now, there's a whole set of things that have happened in ventilator design to try to have modes of ventilation that try to work with the patient and take advantage of the patient's own respiratory efforts. But patient ventilator asynchrony largely describes all those instances where you either consciously or almost by an involuntary basis end up, if you like, bucking against the ventilator. It's an uncomfortable feeling, and you engage in a variety of strategies to sort of fight with the ventilator. And there is the thought that some of that, in addition to being uncomfortable, can also be injurious in and of itself. It can actually exacerbate high pressure injury and so on inside the lung. And so we're not fond of patients having patient ventilator asynchrony. We think it cannot be nice for the patient in the short term, and it could also be making the lung injury worse.
When the clinical situation deteriorates or the patient just isn't getting better, the panel recommended referral for extracorporeal membrane oxygenation, or ECMO. Now, these recommendations have obviously been developed in light of all the new knowledge we've gained during the COVID-19 pandemic. And I think this may be a good segue for us to address whether the recommendations for ARDS, especially for ECMO, generalize to all patients with ARDS, or might they be specific to COVID-19?
You're right. The panel made a lot of recommendations and sort of divided them into COVID-19 specific or COVID-19 non-specific. I understand why they did that, because there were many studies done in just COVID-19. And then you ask yourself, is it the same disease? And the answer is, I don't really know. I don't even know if COVID-19 is the same disease. I think some of the studies done in year one of COVID, when it was all ancestral variant, might not even apply to current COVID, that we've had so many mutations in the virus, the underlying pathophysiology might not be different. I would generally put this in the bucket of, that's one of the problems with syndromes. Syndromes are useful for grouping certain things together, but you may be grouping some things together that actually respond differently to different treatments. So there's a lot of interest, and actually the panel spent some time discussing this notion of subphenotypes or subtypes of ARDS. It is quite plausible that some interventions work equally well for anyone with any kind of ARDS, while other interventions will only work in certain forms of ARDS. That's an area of ongoing research trying to understand, are there different subtypes of ARDS? But to your point around ECMO, since ECMO is basically saying when the patient is in such trouble that the team can't even get adequate oxygenation, even with the ventilator, should you just take the whole thing offline, take the lungs offline, and use a separate device to provide oxygen while you give the lungs a chance to recover? It's probably true that now that evidence for ECMO suggests that there are severely injured ARDS patients who, if they really can't oxygenate, they probably will benefit from ECMO. That's probably true regardless of the cause of ARDS. That's likely to be a reasonably wise recommendation for ARDS regardless of cause, once the ARDS is so severe that regular ventilation cannot maintain even minimum adequate oxygenation.
Dr. Angus, during the pandemic, patients with ARDS seemed so sick with multiple comorbidities, and it was hard to know whether the comorbidities made the ARDS worse or vice versa. Can you talk a little bit about the interplay between ARDS and all the comorbidities that we saw in our patients?
First of all, the patients who get ARDS may already have chronic illnesses that are very problematic, such as bad underlying COPD or heart failure, ischemic heart disease, and so forth. Secondly, when they get ARDS, they can get it along with several other acute organ dysfunctions, like acute kidney injury or altered mental status, coma, etc. The thing we care about is having the patient survive and then survive with high quality of life. It's a really prescient issue to ask the question, when we report a high mortality rate with ARDS, what is it about the ARDS that's contributing to the mortality versus all the other things? I'll be frank, I don't think there's that many patients in modern intensive care who die a hypoxemic death. That's only part of the picture. The problem of multisystem organ failure is a complex one. What we must do is try to not worsen the odds of death. And some of these guidelines really speak to making sure that you don't make the injury worse with the ventilator. But when patients get ARDS, if you provide perfect ventilation and fix the oxygenation, and essentially take the lungs as a problem out of the equation, that does not mean that the patient will necessarily survive. There's still a huge amount of work to be done on thinking about all of the rest of the problem. If it's the rest of sepsis or multisystem organ failure, or the underlying fact that they may already have very severe chronic organ insufficiency.
Before we wrap up, are there any further points that you would like to communicate to our listeners about ARDS?
So I think the only other thing I would say, we took a study in JAMA a few years ago on current practices from around the world in the care of ARDS. It was a bit disappointing that the care was really variable. Although there's lots of uncertainty around some of the things that we do for ARDS, and you spoke about the arbitrariness of the definitions, there are some key take-home messages about things that you should try to do for every patient with ARDS. And those are many of the things that are in these guidelines. Trying to reconcile the fact that we have guidelines based on pretty robust evidence with the fact that practice is highly variable is obviously a source of dismay. And so I'm quite interested in seeing ongoing efforts to work out how we can reduce unwanted variation. It's probably not enough to just publish a guideline. We need to think about how we disseminate the guidelines. Why are people not all following the practice? Did they read the paper and not agree with it? Or did they not read the paper? So, the ongoing challenge to try to make sure that every patient, no matter where they're cared for, is getting cared for by a team fully conversant with the latest literature. So that's an ongoing challenge that I'm hoping to see continued progress in that space.
Well, thank you very much, Dr. Angus, for this discussion and your insightful comments about this very important aspect of healthcare.
My pleasure, David.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMA Network Audio, all one word.com. Thanks for listening.